top county. They were quiet. Then like Tarakanithi, they just showed up and they have about over 200 facilities that are digitalized, and we'll be hearing from Daktari. But what I now would like to hear is Daktari now telling us how they have been using that information that's coming from the digital systems to make an impact. That for us now, when that happens, we will now say as DHA, we have met our primary objective. At the community level, we have HEs, which I know many of us know about, and we're working to fully integrate it into the HIV so that it gets a story of the community. So I always tell people, Kenya is a country to watch. 2-3 years from today, even we will not need a lot of this demographic health surveys that we do. We'll actually be doing it to just verify what we are seeing already. But we will have information in the right hands, being looked at by the right people who know how to look at it. And we're going to really invest in a lot of capacity building at all levels to enable people to decipher what they're seeing from their data. Because now we have the opportunity to look at individual level data. We've moved from aggregate. So digital health transformation is also transforming how we're looking at data. So it's an exciting topic. I can speak about it. But I have seen the benefits. When I was in the HIV program, we did have a very robust campaign called Bring Back the Mothers. I don't know how many people remember, at least I know Dr. Mikigani remembers. And we came up with that initiative from just looking at data and realized there were so many missed opportunities. Actually, the word missed opportunities started in Kenya, if you've never known. Then people, I think we should have trademarked it at some point. But yes, the word missed opportunities started here because we realized mothers were coming and they were missing the opportunity to be done for certain things that should be done within the health system. So we had the Bring Back the Mothers and the Children initiative, and it really sorted out our mother-to-child transmission far and wide. I don't know what happened after that. Maybe they needed a different way of looking at data. But there's so many potentials, and looking forward to hearing what Daktari says about the 200 plus facilities. We're very proud of Makueni, by the way, Makueni County. Thank you.
Thank you so much, Joyce. I think as you said, I hope you guys came early. So we have breakfast, we have lunch coming up, because we're going to be here for a very long while. Right? Yeah, so my name is Dr. Mwatha Stephen. I work in Makueni County as a director for preventive and promoting, but I also double up as a partner coordinator in the Department of Health Services. One of the things that we have thrived or enjoyed is partnership. As a county government, we can't do it alone, and that's why we need partners like the national government to help us with all those gadgets. And we save our resources to put the resources to where it's meant to go, to the patients in terms of commodity. So once they fill in that gap, we have another opportunity for us to utilize the same resources, the minimum resources we have to do other better things. We're also very cognizant with the partners that we've worked with in the digital health space, and especially on data. And a good example is Jacaranda with the dashboard that they have supported us with. And all this allows us from where we sit to aggregate our data. If you look at the digital space, like what the national government has done, from at least from where we sit, we're in a position to use one system for all our hospitals, which makes a lot of sense instead of each hospital having its own siloed kind of software to implement and collect data. So with one system, it allows us to unify all that data. And also from that unification, one of the few things with it, like the dashboard that we have, that was supported by Jacaranda, one of the few things that we have utilized that system is to answer to the 1692 components. If I look at the 16, we were the first county to look at preventable maternal mortalities and implement and pilot heat-stable cavetocin in the country, which now informed part of what the regulations of the WHO implemented on using heat-stable cavetocin for the prevention of PPH. So with that, it actually tells us that it's through the data that we are receiving, and you're noticing it was the leading cause of maternal mortality in our county, and now we had to quickly think through when we got that opportunity is what then we needed to do. So we had a partner, and it's the same spirit of collaborations that was willing to pilot for us, and that really worked out for us in the maternal space, and it has been a game changer. If you look at the cold chain mechanism within our facilities, and especially from where we sit in the rural setups, where not every hospital will actually have electrification, but will have mothers coming to deliver, then a stable molecule that makes sense for us to have that instead of trying to look for oxytocin for refrigeration and for prevention. Then when you look at the 92 and the neonatal aspects, and maybe before I even jump into that, one of the few things that we also notice, preterm becomes a challenge within our county. And we were thinking of the first 1,000 days. So one of the unique things that we have also got with the data that we have received, we had a high percentage of stunted growth as an outcome, and we had a high level of prematurity. So one of the few things that we're looking at is iron and folic uptake for mothers who are coming to receive. Are they really taking it? So as a county, we have gone further because of the malnutrition, because we have all the 3 forms of malnutrition. We have gone further to implement a 15 molecule vitamin angel tablet to allow us to give the mothers to support the macronutrients aspect, the micronutrients malnutrition aspect, and also to allow the mothers to give an opportunity for the first 1,000 days for that child who is unborn to see if we can improve it. We are going to be the first public facility to actually implement what other women go in private facilities, like the pregnant care, what they receive in private facilities. It's actually going to be done in Makueni through the support of Vitamin Angels, and this is also going to help support data to the national team to inform if then this is the direction the government is going to take in that. So anyone who wants to pilot, you're welcome to pilot your pilot in Makueni. Thank you. And you can use that data based on what we already have. Yeah, and we are proud and thankful.
Thank you so much, and I love what Dr. Joyce said. Real-time data, get it to the right person, and then let them be able to use the insights to make decisions, and recognizing the gap that some people don't have the skills, so they're going to the capacity building. But then we've heard from Dr. Mada where in Makueni they have the skills, they're using it. And not only are they changing things for Kenya, but actually for globally, when we're looking at the PPH panel and how it's working. And it's always a pleasure to work with Makueni. But I want to shift gears a bit and hear from Ebenezer in Ghana. My friend, my brother, what's happening on the other side?
Okay, good morning. My name is Ebenezer Amanandu. I'm the Family Health Division of Canada Service. I'm the Assistant Chief Technical Officer of Health Information for the Family Health Division. Actually, I have the data for maternal health, and I'm actually security maternal health and neonatal health. Okay, so in Ghana, we have quite a story, but we've transitioned from stages to stages. In Ghana, we used to collect aggregated data and enter into the DHIS2, which is the Education Health Information Management Systems, which was introduced by the University of Oslo. Okay, so, and which is an open source software. So we realized that one, we couldn't rely on the source of the data. Two, there were a lot of inaccuracies with the data. Three, when it comes to data completeness, that was another challenge. And the timely reporting was also poor because they were supposed to report monthly. Where they were giving timelines, but you realize that they will report as at the time they are supposed to report before 5th of the ensuing month. But you see someone reporting after the 15th. So we have a lot of question marks with our data. So we cannot transition to the fact that we need to collect transactional data, real-time data. So we introduced what we call the e-tracker, which is also embedded in the DHIS2. And we were using that one at the community level. So at the community level, we have health centers and CHIPS, community health-based plans and services. So the CHIPS were collecting data using the e-tracker, real-time data. As and when the client is being seen, the data is being collected. Then when it comes to the secondary and tertiary level, we started using what we call the lightweight health information management systems, called the LIMS. And then we transitioned into GIGS, which is the Ghana Health Information Management Systems. But the challenge we had was that we couldn't build the reporting aspects. So Ghana couldn't link the LIMS to the DHIS2, so that the aggregated data will be automatically automated into the DHIS2 or populated. So, however, realize that the LIMS has its flaws. That's how we came up with the GIGS, the Ghana Information Management Systems, so that we have a reporting aspect. We needed to develop an API between the LIMS as well as the e-tracker. But they were all built on different systems. Some were built on JavaScript. You know, Ghana, we have private sector, we have the public sector. We partner a lot with them. But then their electronic medical record system, we have a lot, quite different number of EMRS systems. And we couldn't link them because they were all built on different systems. So it got to a time we realized that, okay, we need to implement something whereby the private cannot equally use it. So when you point about the games, if you're a private facility and you want to use it, because you already have your gadgets, your infrastructure in place, we only install it for you. Then we start using it. So most private facilities are now using both the LIMS and the games. So Ghana has transitioned. We have a lot of story, but because of the time factor, I wouldn't want to go there. But there was a time we were using pen drive to collect data from a facility, go and merge it at the district level. So Ghana has transitioned a lot. Now let me talk about the fact that what has actually sparked or enhanced our data-driven decision making. We have actually inculcated what you called the improved the use of data dashboards. With the introduction of the AMA scorecard, we chanced on it. That's the African Leaders Alliance for Malaria. So we chanced on it, and then it is color coded, the visuals. So managers actually, because of the doubt the source of the data, they tend not to use the data for planning purposes. So we decided that, okay, fine, we'll let it go. Then what we'll do is that we'll give them at a glance. When you see your performance, the red means you are actually performing poorly. Green means you are more or less doing somehow doing better, and green means you are doing well. So now managers, you'll be there. You will send the dashboard. When every morning they were tasked as part of their appraisal to open the dashboard to look at your performance. So when you see the color, it tells you that, Master, either you are doing good or you are doing poorly. And the way you are praised by that. And in the AMA scorecard, we have what we call action tracker, whereby you can put in action items. Meaning you can put in activities that can be implemented to curb the situation. When you put it to I at the national level have access to it. The one at the national level have access to it. The one at the regional level have access to it, as well as even your own providers. So everyone have access to it. So when you do not implement the activities to improve the maternal health outcomes, everybody sees it. And you are being appraised with it. So it's actually made managers to now sit up. And also the system realized that initially, because we're collecting aggregated data, we're not doing like real-time death audits. What we're doing was confidential current maternal death audit. They will wait at the end of the month or at the end of the year, the maternal deaths that they've had, they will sample it and then do the auditing, which was bad. So when we started the transactional data collection, now when the death occurs within 24 hours, the team has to meet to audit the death. So that brought about the maternal and perinatal death audit. We call it the MPDSR. which Ghana has just started. And we have made it electronic. So, as at the time a death occurs, you are supposed to notify national level that a death has occurred. Because Ghana is aiming at reducing preventable maternal deaths and neonatal deaths. So, where we are moving towards, we have moved from reducing maternal morbidity and mortality. We want to reduce preventable maternal deaths and neonatal deaths. That's where Ghana is moving to. And now we have what we call community scorecard. We want every facility to be accountable to the health delivery of to your catchment community. Now, the community, we have what we call community health management committees that meet every quarter to assess the facility. We have 9 signal functions, and the respectable care and whatever. They are 9. They assess the facility, they meet and vote, and then score you. When they do the scoring, it's entered into the community scorecard, and everybody sees it. So we know your performance, we know how you are treating the people, and we know how cleanliness the facility is. And the scoring, you don't sit in because you are not part of them. They score, they do their entry themselves. So it is independent. And now, we have the patient-centered approach, the one that was introduced by Prompt. It gives us real-time data. You understand? But the patients express their grievances, they express how they are being treated and everything with the true SMS and the voice over. It makes us as managers see what is actually pertaining on the grounds. And due to that, I can tell you for a fact, some managers are not being appraised. And it has made them accountable to the catchment population they are serving. And that has made us, so actually, it has made data to drive decision making. Let me just give you examples of what has helped us. Now we have what you call the free maternal health services and free family planning services. And these were all data driven because of the transactional data collection we are doing and the real-time information we are getting from patients through the prompts. Thank you so much.
Thank you. Very insightful. I think I love the journey that you've taken around. You didn't trust the data, but you fixed it. The source of the data, you fixed it. But I think for me, the things that I heard was, first of all, transparency at all levels, accountability, and then the inclusion, again, at community, the patient, the region, the district, as well as national government. So really great work, very exciting. So we'll shift gears a bit, and from government, and I'd like to go to implementing partners. And as we're going through Africa, I'll start with Valerio, who's done some work in Tanzania. He's an implementing partner. I'll let you introduce yourself.
Thank you, Cynthia. Hi, everyone. I'm Valet, Program Officer at Touchdown. We have been working for the past 20 years across Okay. 20 years working with many countries in Africa to help with building health systems. And in the past 13 years that I've been with Touch, we always mingled with data and trying to understand how to make it work. Right? And I've had my share of failures, I think. It's allowed here to say we need to be positive, but also realistic. Failures, but also success stories. And I think that from our side, when data was used and was used properly, we saw an actual impact at the end on the patients, but also on the people that work in the system, decision makers, doctors, nurses, community health workers. I wanted to share today a little bit, an example of what we mean by proper use of data, right? So, and like any success story, I think we started from talking to the people that are actually doing the work, right? So in the hospitals that we work with in Tanzania, we were talking to doctors and nurses that are taking care of newborns in those hospitals. And one of their big frustrations was that they do so much work caring for the newborns that are delivered in those facilities. But then they were telling us, we don't know what happens to these babies once they leave the facility. There's a lot of support coming also from partners, from the government, in the facility itself. But then I see this baby, they also call them by names because they stay there for so long, but then they don't know what happens once they leave. So we took that challenge on, and the idea was, can we use the data that is already available in the hospital to understand what are the babies that really need help after they leave the hospital, and how can we provide that help? This is what we call now Watoto Care, is a program in Tanzania that we're running for the past 2 years. And how it works is, it's quite simple. We set up a triaging system. It's an app, it's an ICT app that is nothing so complicated, but takes the data that we have at discharge and flags to the hospital which are the babies that need that extra care and follow-up once they leave the hospital. And what we added is the possibility for the hospital to bring doctors directly to the home of these babies with teleconsultation. So instead of hoping that the baby comes back to the hospital, we are able basically to bring the hospital to their homes. Now, the idea is that why is data important here? Because I think we all wish that we could do this for every baby, but it's not possible, it's not feasible. So the data really allows us to focus on the babies that actually need that care. That's the first thing about proper use of data. So I'm taking an angle slightly different than what my friends from the government are taking right now. That is, there is data available already. How can we use it in a way that actually makes a difference in the everyday life of doctors, nurses, and ultimately of the patients themselves? But also, that allows us to minimize the costs of providing these extra services, and that's when our government counterparts were engaged, because they know that they can't sustain anything that costs too much. The added value of having done this is that before this program, the question of what happens to these babies was there, but nobody really could answer. Now we follow up these babies into their communities, and we start understanding what happens to them, right? So this is for us proper use of data, and starting from the data that is already available. Let me tell you, just to give you some numbers, Watoto Care now has been running for a year. We enrolled more than 5,000 babies. The hospital delivered more than 2,500 teleconsultations to these babies, and that starts to show almost a twofold increase in babies achieving all 4 postnatal care visits, right? So we're getting up to something. Now, the data really allowed us to do 2 things. One is to have an impact on the everyday decision making at the hospital, deciding which of these babies really need that extra care. But also the second, that probably has an even greater impact in the long term, is that the Ministry of Health in Tanzania recognized that postnatal care is so important for the health of these babies that they added it to their strategy. Before, it was mostly based on antenatal care and perinatal care, so what happens in the hospitals. But they added to their strategy also postnatal care, because they saw how effective that is in terms of the babies that we were following up, and we shed this light on what happens next after they leave the hospital. So that's my story and of success. In the Q&A I can talk off.
Thanks for being honest. We never share our failures. We only share successes. But we get there through the failures. That's also how we get to the success. Maybe speaking about how you know, it's amazing, but because postnatal is really forgotten, and our babies are forgotten, and yet they are the future. But yeah, just like to hear from Siglinda, of course I'm biased. Just how are we using data to actually impact the lives of our moms and babies?
It's very tough to be on a panel with your boss because she's going to listen to everything you're going to say. But good morning, everyone. It's a pleasure to be here, and thanks for joining Jacaranda Health to host this very amazing conversation. My name is Siglinda Ngeni. I work at Jacaranda Health, just driving this work behind working with county governments to drive data use for decision making. And very happy to have Dr. Mwanga on this panel because Makueni County is one of the counties that I support this work. So I've been doing this project for the last 3 years in 3 key Kenyan counties, with the North Star of the project being driving data use for decision making. As Joyce highlighted, I think in Kenya the problem is not data availability, but the thing that we need to catalyze is data use for decision making. She said something around supporting real-time data use and making sure that it's in the hands of the right users for there to be actual data use. So I'll share a little bit about how we've been doing that on my project. So we started this project by understanding what are the needs of our stakeholders and what are some of the gaps that exist when it comes to data use. And it became quite quickly that maybe supporting data visualization and supporting systems that will allow continuous data use would be some of the pathways to facilitate data use. So in Makueni County, Kisii County, and Mombasa County, we developed this dashboard that Dr. Mwata has referenced to support our stakeholders so that they have access to digestible data that is quite easy to look at and to generate insights. But also we built a lot of mechanisms around, can we hold spaces where stakeholders can have frequent data review meetings to look at the data and then go back to their facilities to continue to use the data. So to share my experiences, I wanted to share some of the wins that we've had on this project around data use, and I'll give 3 stories from each of the counties. So in Kisii County, one of the things that they did once we provided them the dashboard is really do a deep analysis to understand where our maternal mortality is coming from. And in the analysis they saw, yes, 70% of mortalities are coming from public facilities, but there's this chunk of 30% of mortalities that are coming from private facilities. And then the department had to take a step back. How are we involving private facilities to make sure that they're also in this fight for improving outcomes? So Kisii County then, because we provided them with this data, decided we must include private facilities in this conversation. So they started to involve the private facilities in their MPSR meetings, and also supported private facilities in terms of taking up the EMONC mentorship, because it's not enough, I think, to improve the public sector, but it's also really important to think about the private sector as well. I think Makueni is one of my best use cases for data. As you all know, Makueni is a very forward-thinking county. So when we came to Makueni County and we were painting the picture around, there's been a lot of investment that has been made to improve outcomes for mothers. Behavior change is improving, but we're still not seeing outcomes improving. And because of the data that you provided, Makueni said, we think there's an investment case here for creating a results-based mechanism financing so that we can particularly incentivize improvements of care for maternal and newborn babies. So Makueni generously in the first year dedicated 4.3 million shillings, and we picked key indicators on maternal care, And Makweli provided this funding for us to incentivize healthcare workers for them to improve outcomes. And all of this is because we presented the data to the county and told them, if you want to see improvements, these are key areas that you can make investments. Lower level, again in Makweli County, through this project we've been able to do what we call facility quality assessments, which we digitalized the tool that DRMH has around collecting assessments in facilities, and we're able to show facilities. In your facility, the gap that exists, for example, is on equipment. So one of the facilities in Makweli County took this data to say, we don't have enough centrifuges, we don't have enough Dopplers, we don't have enough, and Dr. Mwanda can talk about this. And so they made a really strong case for them. They said, we are referring facility. Why do we not have this very basic equipment, yet mothers are coming from all corners of the county to seek services here? And what they were able to do with this information is advocate for themselves to get this equipment. And then in Mombasa, I think I talked, for those who were on my panel on Wednesday, I talked about the case of Mombasa and how they use data to advocate for the operationalizing of an NBU in the county. So in my experience, I think to what Joyce has said, when we provide end users with real-time data, we really empower them to advocate for themselves and also to make a strong case for where investments need to go. So at the lower level, it can be a simple investment as making equipment available, and then at the higher levels, it could be bigger investments around where do finances need to go. And I think data can be a really good driver for this change that we want to see in the space. Thank you very much.
Thanks, Linda. I was just, what you were talking about is, also data visualization, and Ebenezer talked about that as well. And even at Jacaranda, we focus a lot on data. We have our own dashboards, and it's something, you can know something. You can know that we need this more. But when you see the data, then you see the reds and the gaps and this is a level 4 facility and they don't have basic equipment, then it triggers something and it triggers action. In the interest of time, I will move to Iyaduni, but I'll ask you to answer the 2 questions. First, how, as a donor, as a funder, you have all these organizations coming to you, focused on country plans, but how do you make the decision? What kind of data do you use to make these decisions? And as you're making investments, and then also just the last question, which I'll ask you, which everyone will go around and answer, is what's the one thing you would like to see change in the space that we can act on today, that next year we'll be able to say, hey, this has changed around how we're using data? So, 2 loaded questions, yes. But yeah.
Thank you, Cynthia. Good morning, everyone. My name is Iyaduni Olubode, and it's good to see a lot of familiar faces here and new faces. I've been christened Wamboy since my travels to Kenya. I'm responsible for MSD for Mothers programs in Nigeria. I've been responsible for the portfolio in Nigeria since 2018, and just recently got allocated the Kenya programs as well. So I've been spending a bit more time in Kenya as well. Now, for those of you who don't know MSD for Mothers, MSD for Mothers is an initiative of MSD, the pharmaceutical company. We're known in the US and Canada as Merck, but everywhere outside of US and Canada, we're known as MSD. And MSD for Mothers is an initiative of the company focused on improving maternal health outcomes globally. And we work in 4 focus countries: Nigeria, Kenya, the US, and India. And so we were asking, how do we make our decisions? As an initiative of a pharmaceutical company, data, evidence, the science is always something that has inspired and informed the decisions that we make. It is helpful when the government sets priorities, because everything that we do starts with explicit, well, it's helpful when they say explicit priorities and say this is what we want to do. We expect the government to take the lead in this area and we lean into the government, we follow the direction of the government. But it's not always as explicit as we would like it to be. And so a lot of engagement goes in there, but also finding out. Ebenezer spoke about MPDSR, and it really started, I think, for me in Nigeria. If I use the example that we had, we were trying to understand why are women dying. We knew that in Nigeria, most women were actually having their babies outside of healthcare facilities, and so whatever data that you're collecting in your healthcare facilities is not really giving you the real reason why women were dying. And so we funded a little effort that went into the different geopolitical zones to have sort of what we call a verbal autopsy, speaking to people to understand who had died recently, understanding what happened, she bled, she was convulsing, just basically understanding it at that basic level to understand what the patterns were. And from that conversation, we were able to establish that PPH was the leading cause. We were able to establish that preeclampsia was following closely. We were able to establish, so many things around why women were dying. For example, that TBAs were alive and well in all the geographies. And so if you had to address them, you couldn't completely ignore them. And so this is how we looked at data. How do you understand the problem better? We have MPDSR that helps you to understand why women are dying. They're not getting medicines, or the medicines are not working. We talked about heat stable capitalism. MSC for Mothers have done a lot of work understanding the efficacy of oxytocin, understanding in Nigeria from research work that had been done by lots of other people, and it doesn't have to be your research, but understanding there was some USP Commission work around how the quality of medicine was, I think 72% or something of the oxytocin that was on shelves was of poor quality, and it needed to be kept at a certain temperature. And after commissioning a further study to speak to healthcare providers, they confirmed that, oh yes, we use 1 or 2 or 3 doses because we're not getting the right efficacy. This was information that was out there, but nobody had taken the time to collect that information. It was anecdotal, but you can't use anecdotal evidence to advocate and to see a system change. When that was published into a report, when it was facing decision makers, staring decision makers in the face, they had to do something about it. And so I think data is vital in understanding the problem. It's vital in being able to, because many problems are nuanced, and being able to get to the first place. So one layer of data is great, looking at that data as well and understanding what is the next level of data that is required. I also think that we can overdo it with the analysis. So, understanding what's the next level of information that is required, I think is critical. Coming up with a solution as well, you do need data. Testing that solution and being able to show what insights do I have. Valeria, you talked about existing data. There's so much data sitting in so many places now. What are we doing with the data that we currently have? And how can we aggregate it and put it together? We're doing a wonderful job, Jacaranda, putting together information from women, providers, and the system. Wouldn't it be great if we could see organizations pull data together for, say, money? So it could be Jacaranda's information, it could be somebody who's collecting information around commodities, another person who's collecting information that isn't there, but gives us a full story. It helps us to understand better what's going on with Ukraine. So I think in terms of what I would like to see, it's breaking down organizational barriers around data and trying to bring that data together to be able to support, for example, Macquarie. It is collecting data, but also looking at the data that already exists and how we can use it to tell a story. Thank you.
Okay, the one thing I would like to talk about when it comes to improving upon data prepared, I will talk about shared responsibility. You know very well that everybody thinks data is the business of information business. When they talk about data, they are looking at information business. Managers think, oh, but I would think there should be a mind shift whereby managers they will build the capacity of managers so that they will also understand the essence and the use of data in planning. Otherwise, it will still be the same norm whereby everybody will think that information officers are the only people who are supposed to manage data. But then we should build capacity of managers at all levels of care so that they will use the data at their level. Thank you. Yeah.
Well, I think following up also on what Yaduri said, for me it's important to understand where the data comes from. And we must not forget that a lot of this data comes from the front line, from the health workers that are doing work in the hospitals or in the communities. And what I would like to see is that data doesn't leave the front lines, meaning that it's accessible real time, live, from the people that actually collect it, because those are the people that need to use it. And I think we have no more excuses not to do that with AI, with the new technology and everything. So that's what I would like to see and talk about next year.
Thank you so much. Just a follow-up as well. I think for me is I look at, once we have this data, how do we then ensure that the policymakers, the people in leadership also get to synthesize the data that the healthcare workers are utilizing for the purpose of resource mobilization? Because if they don't have the information as that the technical people have, most of the resources will go into roads. And we already have a budget declaration of 15% of that budget. So how do we then utilize that data that we collected from a technical perspective to be placed in the policymakers' components? And a good example is like the PPH story. His Excellency, the Governor of Makwini, is actually the national champion of PPH. So even in terms of policy decision, he knows that X, Y amount of money has to be allocated towards that. So maybe that would be a better utilization of data into that policy decision-making component. Thank you.
Ebenezer and Dr. Mwanda have literally said exactly what I wrote on my piece of paper. So I had down the same exact thing around building capacities of healthcare workers across all levels to, use data. We should not leave it to be the job of HRIOs only, but data utilization can only work in a system that has power to take action. So to Dr. Mwanda's point, thinking about the policies we need, the political will we need, and the financing we need to truly drive data use for decision making.
Okay, so next year, at such a time, I would like us to have very deliberate discussions about how data has stirred up conversations. That is what DHA is looking forward to. So DHA has done certain things to get us there, has figured out how to bring real-time data, has figured out that capacity building is needed, of course knows that data visualization will help, that data can be, is really useful for even doing predictive things like our colleague in Tanzania said. Because we've done it before, it's not the first time we're doing it. We've done it heavily within the HIV program, at least. That one I can say, we've done it. But now what we are doing is scaling that up so that counties do not have to be having conversations about quality of data, but rather, what is this data showing us and why is it showing us this way and what can we do to shift, or to change, to make things better, or things are already better, so we are happy, patients are happy, providers are happy, things are going the way they go. So start up the conversations. So we'll want to see those conversations happening at all levels, right from the community to the policy making level. And it will be interesting to see how things look like even at sub-national unit. One of the things we've learned, and not learned, we've seen after many years of being in this space is leadership is the one thing that nobody talks about. So like when I'm banding the counties so that I can know where to start for digitalization, my team always knows there's Joyce's indicator, and it is about the leadership. It's a soft indicator, but where there's leadership, then the rest happens. And once again, I mean, Makueni is where it is because the technical team is on top, you know, right from Dr. Mwatha and team. And then they have passed that on and wrapped that off on their governor, who was also willing to be on top of things. So in such a county, when we're talking about digitalization, DHA just does, and we know the rest they do. So it's the other thing that we'd really like to put up front. So congratulations once again. And to our partners, we cannot do digital health transformation alone. It cannot be done alone. And that also falls under the data conversation, data starving up conversations. The right stakeholders have to be in that room for things to start making sense. Thank you.
So I'll sum up, and from what I've heard, you know, as you're saying, the right stakeholders. I've heard a lot about the community being involved, the providers, who are the data collectors, who are the front lines, being involved, the leaders need to be involved, the moms need to be involved also. But then I think what I also heard was that this has to come back to each and every person. So yes, you provide the data, but are you getting feedback on how it's being used? Are you seeing the change in how it's being used? And I think with what Ebenezer said, also the accountability and the transparency that's there. And I think that's what will lead to us breaking down barriers and also having shared responsibility in what we're seeing and in the outcomes. We want to open it up to our wonderful audience who have been listening. It can be a Q&A, or you could even comment and share how you are using data, because it's not just about us. We also know that people out here are using data. So we'd like to open it up for 10 minutes?
Yeah, 10 minutes.
Yeah, for 10 minutes.
Thank you to the panelists for such a brilliant conversation. I really enjoyed it. My name is Anne Musuba, I'm a health system specialist. I mean, we've heard of the amazing innovations, prompts, the telehealth in Tanzania, the quality improvement system that you've now digitized, and that's amazing. And for someone who's interacted with prompts, I think I've seen the impact that it has in terms of directly improving maternal health outcomes. So my question goes, I think, to all of you, and I'm asking this question with President Trump on my mind, and with the changes that we've seen in the global health financing architecture this year. So all these are amazing innovations. Joyce, we've had very many innovations in the health system, digital health innovations brought about by various partners. Prompts is an excellent example. How do we make sure that as a country we are taking the innovations that have, I think, proved or tested themselves through the health system and integrating or scaling them up so that they are not just maybe covering a fraction of the population? What sort of systems do you have for that? Because I guess we need to have a way of prioritizing and seeing what really works, what doesn't. Because there's also other innovations out there that won't work. To our funder, how are you incentivizing your partners to think through sustainability, or to make sure that the innovations that they bring on board are actually supporting national systems, can be integrated on national systems, and don't just die down with the end of projects? And I think the same to the partners as well. How do you have the end in mind when you're starting off supporting countries, counties with all these different digital innovations? So my question is really on sustainability. I think it's very clear to us as a continent that we really have to move forward with the new Africa Health Order. We really have to think of sustainable innovations. Thanks.
Go back here.
Good morning. My name is Jamai Makuta. I work at the Council of Governors, and it's really a great honor to be in this meeting this morning. I want to appreciate Jacaranda Health for bringing together a very rich panel with very good insights and innovations that all of us have taken note of. So at the Council of Governors, our major role is to coordinate the devolved functions. We all know that health is the most significantly devolved function for county governments. And therefore, I heard in the morning the co-executive director for Jacaranda Health mentioned very chilling statistics. We all have heard about them over and over, 16 mothers dying every day, 92 newborns dying. And this has not sat very well with the Council of Governors. Recently, we launched an initiative to just try and address the issues around maternal and perinatal deaths. That is the Inter-County MPDSR initiative, where we have components of bringing together the healthcare workers, the frontline workers, peer-to-peer learning amongst them. We have a dashboard that monitors the critical indicators around maternal and perinatal death. We have webinars that we are carrying out every bi-weekly, just to try and address the issues around this. And today, we are convening the County Health Information and Records Officers, because we also realize that some of our data might not be of quality to use to make decisions. So we are convening them to have a discussion around them improving the reporting rates in the KHIS, so that to enable us to have real data that can enable the policymakers make decisions. So this is just a comment to say that we really appreciate the partners who are supporting the county governments, and especially supporting the people who generate this data to enable the policymakers make decisions. So thank you so much. And,
Any other questions?
Thank you so much. I think this panel was really, like, you took time to think through your presentations, and it's sparred, or it's triggered in me something that keeps me up a lot at night. And that is, you've rightfully said there's some data we have had for a long time, like we sit with data. We as humans are pieces of data walking around. But then what keeps me up at night is, what's the catalyst that moves data into action? I liked when Dr. Wanishwe mentioned, it's data that identified missed opportunities that got Bring Back the Women campaign. But we've also known for a long time that it's a tragedy that women and babies die at the rate that they do. But we are sitting on this data, like we say it, and then we have tea. And this is really like, should be a catastrophe of epic levels. So I think just that reflection, what's the take, or what's that movement that we need to shift this consciousness of this is data, this is the action we need to take in order to end up with outcomes that shift our populations and our communities. Thank you.
One more question. Sorry, can you pass this along?
Hi everyone. First of all, I'm so sorry that I'm late to attend another session, but I'm also very pained because I'm hearing a lot of the comments coming from participants about how great the panel was. But one thing that came out of this is that I'm also hearing the comments people are making, so I feel like I should share my experience from the work that we've done. So my name is Dr. Lamide Okulaja. I'm the Chief Growth Officer of MyShemeds. And one of the things we did, you know, in terms of what you said now, I think the first advice I would give to any organization, especially innovators like us, is number one, don't exist. And when I say don't exist, I don't mean don't exist as an organization. I mean there's a tendency that as organizations, when we do work, we want to claim that work because that is how we traditionally raised funding for us to continue our work from the donor world, from developmental partners and all of that. And you know, with my sister here that has Trump in her mind, that was the first thing we started thinking about. Or I personally started thinking about 2 years ago, that what if all this donor money ended? How would we move ahead? And one of the things that we did was to say, if you want to scale as an innovator, if you're generating data as an innovator and you want to move it to the next level, what you need to do is to partner with governments. Partner with governments, not necessarily to show them what you can do, but identifying the problems that they have and looking at how your solution can help them solve those problems. And I'll give you an example. MyShemeds recently, we're about to conclude a program in Lagos State. It's ending in December. And this program was funded directly by the state government. And one of the problems they had was that there was a dichotomy in terms of the malaria indicator survey that said malaria was about 2% or 3% in Lagos, but numbers coming out of DHIS2 was about 80 to 90% positivity rates in malaria. So they needed some data that was evidence-based to be able to make policy decisions. And that's where MyShemeds came in. We also went into a lot of partnerships. So we just didn't go in as an organization. We partnered with the WHO, with the National Malaria Elimination Program, with the Pharmacy Council of Nigeria. It was a whole cohort of partners. But out of that, the data that was generated, which showed that malaria positivity in Lagos is about 5% of a cohort of 75K tests done, has now informed policy to limit microscopy to high specialized areas and RDTs in primary healthcare centers alone, is now enforcing policy to ensure that for every malaria test that is done in Lagos, you have to test before you treat. And for the first time, is now informing policy to allow private sector data go into the DHIS2. And this was because we were able to prove through the data that we collected in a way that demonstrated or aligned with what government was trying to do to be able to enable them go through that policy change. Going forward, most of the funding that we're going to get as innovators and as organizations will come from government, either way through funders or through government themselves. So it's important that we begin to look at governments not as clients, but as partners in being able to achieve the goals and outcomes that we have.
Yeah, so we'll have 5 minutes for answers. I will shift a bit of the order that my questions are. I think we'll start with Mongoy's question around what do we need to catalyze the move from data into action. I'll actually to take advantage of the missed opportunities. Dr. Mother, I will have you answer that question. Then we'll move to the sustainability question, which I think is just excellent. And we'll start with Valerio to talk about how he approaches sustainability. And then Mamboy, Iadri, we'll go to you. And then we'll close with Dr. Joyce.
Thank you so much. It was actually more of a comment than a question. But for me, how I look at it, data is a process. And I think for us is looking in at it from the very initial beginning of collecting it to the action that you're going to take towards implementing what gaps have been identified. and this is a call even to the partners that even when you're doing any project, you're not doing a project and then coming to present to the government, this is our finding. You're actually journeying with the government through the entire process. So they are part of the process, and once that integration is done from the very beginning, from the conceptualization, because you see the challenge that comes in sometimes you create something, then you come and tell us, this is what we have created and we want you to utilize it. That becomes a challenge, but if you engage us that this is what we are thinking of creating, do you have feedback, do you have comments towards it, then already we have been part of the co-creation. You may have done the foundation work, then we come in to give our input so that even when you start utilizing it, it actually becomes a collaborative affair that you're doing it, and that's going to make the gap of implementation from data to action. I think that was one of the few things that I've seen work in our county, and that would be what I'd actually recommend as a tangible evidence of the things that we have worked. And it also ties along with sustainability, as was being mentioned, because part of what we have noticed as government is if we on board from the very beginning, we always have sustainability, because we always talk about transition plans with entities that work with us, because there is that discussion that this is what we have done, this is our achievement, how do we then sustain the gains of what we have done? Because you notice a quick example of sustainability is when I talk of PPH, we were given donation for 36 facilities. We have 242 facilities. We realized that this is just a small piece of what we got. So we invested more for the other facilities that were not in the pilot phase. That has allowed us that even when the period will end for the donor for the 36, we're already in the process for the other facilities. And I think those are some of the learning lessons, a practical example that I can give. Thank you.
Thank you. And one comment before I address the sustainability question, because what moves data into action for me is very interesting. I think I would like to say that it's not really data that can go to action, but there's an intermediate step that is insights. If we do not build insights from the data, there's no action that can result to it. That's sometimes the mistake that we do, because we're working with data all the time probably, and we automatically go to action because of that data, but there needs to be the insight for the people that are not working every day just focusing on data. So I wanted to just comment on that. And to the sustainability question, I think from an implementer point of view, when we embark into something, we always try as hard as we can to understand what sustainability looks like. And in my mind, we have this framework in which, first of all, there's no sustainability without impact. If you're not having impact on the patients, nobody's going to sustain your solution. The second is cost effectiveness. If you're doing something that costs more than what is already happening, why are you doing it? There's no reason to sustain it in the long term. Political will, making sure that everybody involved knows about what you're trying to do, is involved into structuring and into the solution, the design of the solution. And then I think I look at you, because patience for me is the fourth component that brings sustainability. And I look at you from the funder's perspective, because sometimes that's the most difficult piece of the puzzle, that when funders come in with the right patience to look at sustainability in the long term, that's when we were able to achieve something. So that's the response from an implementer.
So I would like to share a success story when it comes to sustainability. Right from what Dr. said, when we start with the government, and the government feels part of the implementation process, it helps. Like in Ghana, the heat capital we were talking of, the government of Ghana has actually involved local manufacturers, the pharmaceutical companies, to see how best they can produce the heat capital in country, even with the calibrated drips. The government of Ghana has also actually involved the local manufacturers who are doing the rubber, whatever, the plastics, to actually look at how best they can manufacture the calibrated drips for the e-motive in country to measure the blood loss for the PPH. So if the government force involved right from the beginning of the implementation process, that's when the government makes sure it sustains whatever has been started. Thank you.
Thank you very much. I think everybody has actually said, very critical points, but I wanted to really piggyback on something that has been said already. I think, like we said, the government priorities, what has government articulated and explicitly stated as their priorities, and how does the work that you're doing fit in with that? We want to see in a funder, in an implementer, people who are already working with the government, who have presented solutions. Their solutions must be, we need to go beyond cost effectiveness. You need to be tailored to government budgets. As a private sector organization, we've worked a lot with other private sector organizations, social entrepreneurs, who create scrappy solutions, because sustainability has been on our minds way before the beginning of this year. We've also been quite patient funders. We've supported this initiative for 3 years, and the work that we did on introducing the WHO PPH standards started with that research around why, what's happening, the USP research, understanding the issues, seeking and identifying what medicine could address that, going into a tripartite partnership with WHO, Ferrin, and ourselves. And then, now we're partnered with the Gates Foundation in Nigeria to see how that can be, PPH management can be scaled nationwide. So it's been a journey, and I think we have to look at this as a journey and not be in today and out tomorrow. We have a theory of change around how to improve maternal health outcomes. We believe that if women have access to quality care, we will see improvements in that. But we look to the government to say this is what we want to do. And we look to the implementing partners to work with the government to achieve that. And what does that look like? It looks like being clear on who carries forward the work in terms of operational sustainability. We're going to do this, but if you step away, who's going to do it? And so let's bring those people in. It takes longer, and they say if you want to go far, if you want to go fast, go alone, but if you want to go far, go together. So it's a longer journey that has kept us in the game longer, and that really points to your point, Valerio. But I think really starting with the end in mind, collaboration with other stakeholders, and looking for the scrappiest solutions, because if you don't start scrapping, nobody's going to sustain an expensive solution. Thank you for an amazing panel. Just wanted to acknowledge all the speakers here for making this such an easy conversation. Well done.
Thanks. Yes, panelists, thanks so much. It's been a pleasure having you, and thank to everyone. And I think just to wrap up,
So maybe I'll do a good job of summarizing what you wanted to do, yeah? But there's one question that Anne asked that I want to put out. Dr. Mwatha, if you ever wondered if I went to med school, Anne is my So I definitely would not like to leave here before I respond. So innovation, very good topic, and we're always talking about it. And when DHA came on board, there are people who felt like, oh my God, DHA is coming to stifle innovation. No. If we even look through the Digital Health Act, we put it out there that a lot of what we're going to do is going to be coming out from the many innovations that are going about. We start with itches. Itches is an innovation. It's not DHA that came up with it. But at some time we had like 30 small itches, if you recall. But what made the difference is all those partners coming, and now reading into the bigger vision that government has, that there shall be a system that will be used by community health promoters. So they came and we worked on having this one ICHIS that is now being utilized. When you think about like the NCD modules that we are having in our Taifa Care HMIS, DHA would have decided to come up with one. But we looked around and said, oh, there is SPICE. And SPICE can be the module. And then we improve. So same thing with prompts and all those other innovations that we have. Kenya, we are always innovating. I'm very proud of our local capacity. And yeah, Kenya is in fact we should be the Silicon Valley. Yes, we need to turn it to that. Excellent brains. And what we now are working on having is a space where innovators can come and present in a space, what we are calling the digital technical working group or something, and present so that we are always picking the best for scale up. Now the only thing is, innovations are picked for scale up if you do what Dr. Mwatha said. If you're working in a corner and DHA or government doesn't know what you're doing, then you just pounce onto DHA and say, hey, I have this innovation, and we don't know what you're talking about, we don't know what you're bringing, then that will create some sort of challenge. But the second thing is letting go. As a partner, when you're bringing that innovation to the government, are you ready to let it go? Yeah. I mean, that's something we have to ask. If you still want to keep on carrying it, then we're not going to have a conversation. No, I'm not looking at you. I'm just putting it out there. So that we all know what we're talking about, and for the people who they are competing, they really know. So if you're willing to let go, then the conversation is very easy. Yeah, so and I hope we are not stifling innovation, we are pro-innovation, we want the best out, and that is why we don't even want to say that there shall be only one Taifa Care HMIS. So Makueni had their thing, we told them, oh, we like what we're seeing, you like it, good, get onto the highway. For the facilities where you don't have your thing, you can consider this other. Isn't that how the conversation went? Did we force you into some strange space? No. But then now, back to the next question, to what Dr. Muthigani asked. Action. For data so we have lots of data, but it's just hanging. I want to put it in a better way. He used the word insights, but our data is just there, stagnant. So we know it's there, but nobody has looked at it, or nobody is making sure the insights get to the place that they need to get to. But I recall when I was a young medical officer, when a maternal mortality happened in a facility, we actually had to do the audit and report 24 hours. And we recall that. But why were we doing that? It's because there was leadership that was intent that we know there was a death that happened. So we are expecting that maternal audit. I've done several, and the one thing it always made you feel, you kept on asking, what could I have done for that woman to be alive? A woman has come in eclamptic and she passes on despite everything you've done. But you could carry that guilt, if I may use, and keep on asking yourself, what could I have done? And definitely the next such patient that showed up, you definitely behaved in a slightly different way. And I can see those who are understanding what I'm talking about feeling it. So when devolution came, counties went into their spaces. There was no longer that national looking at, there's been a maternal mortality happening in Marsabit and happening. So counties were all to pick that and sort that out. But through DHA, we are hoping, working with COG, that we can bring back, the visibility of such events to a national scale. And be able to say, by the way, County XYZ, you seem to be killing a lot more women than County A. Yes, because that's how bring back the mothers also worked. So that takes action to a different level. And we all now begin to see that we have to be very keen in what we're doing. The other thing that DHA will be doing is there's a new bill on quality of health care or something. And we're really pushing for the accreditation component. So if you want to kill the bill, don't kill the accreditation bit, yeah? Because we look forward to being able to accredit facilities from a quality component using the data that we are seeing. So if our patient is coming and your outcomes are always resulting in sepsis or stop, we want to look at that facility a little bit different from another facility and find out why all your patients there is sepsis, okay? And then be able to say that you're a 2-star or a 3-star and keep on updating that, not from a punitive perspective, but from a we improve perspective. So that then patients decide, I'm going to go to this facility because it's a 5-star, even if it's a health center. So the quality bit. So those are some of the things that we have as DHA to spur us into action. Move the data to insights and then put it in the right places for people to see and have that discussion. On sustainability is a very, very big, now is my favorite topic of late, sustainable financing for digital health, for data. So for Kenya, we already have kind of figured that out. If you pick our regulations, you will see how we are thinking that we can be sustainable long after we are done with our various other financing models that we are currently in. But the one message we're passing is data is expensive. There's a huge investment outlay. It results in very good things, but somebody has to pay for it. So how do we do that? Definitely, when government is on top of things financing, then that is more sustainable than any other model. And we are really liking what we're seeing. We have different types of counties. We have those counties who say serikali saidia and they are waiting for government to give it everything. But we have other counties that say, oh, this digital health own shilling also, the outcomes are much better. Because we even see in terms of data use, it's much, much better than that county who's sitting back. Like till today, there's a county that is least bothered about digital health transformation, has not approached DHA, and I don't know, we are waiting. We are waiting for when they will come. But there are other counties like Makueni could not let you sleep. They're asking, when are you coming? When are you coming? When are you coming to digitize? But there are others that can let you wake up. Yeah. It's about leadership at the end. Thank you.
Thank you. So I think, and sustainability, next panel, because that's, I think, a whole other discussion in itself. I was just looking around the room, and we talk about the data, the insights, and what planning means. There are a few people standing because there's no seats, and I'm just relating it to our 16 and our 92, and the people seated, it's good planning. The ones who are standing, we couldn't change that. But I'm making light of it, but it's the truth, yeah. Like, just those are numbers. We need to understand what's behind the 60. It's not just a number. It's what's behind it, what's driving it, what's the root cause. And I think another big theme I've heard, which is don't go without government. You have to go with government. I always tell my team, when you go to the county, when you go there, I'm like, that's their home. Yeah? You don't go into someone's home and start telling them, move this chair here, put this here. You have to do it with them. I think for me that's very key, and national government. But the three things I think I'll take away are inclusion all the way from the mom, the community, the providers, the facility, the sub-regional teams, the policy makers, implementing funders and funders. Insights, so not just data. Data is data, numbers are number, but let's have insights. and leadership and accountability. Thank you so much for being here this morning. Thank you, Pamela.
Okay, I'm here.